presentation addresses pediatric mental health issues. 13 to 20% of children and adolescents in the U.S. require mental health care. However, only about half of these actually seek treatment for care. Part of the reason for this is a severe lack of access to mental health providers and a shortage of child psychiatrists. The American Academy of Pediatrics and the National Association of Pediatric Nurse Practitioners both call for assessment of family psychosocial functioning and assessment at every well child check and routine screening for mental health issues using some of the validated tools that are available when working with children. So there are several influences to mental health conditions in children. The most obvious of these is the genetic predisposition to have mental health conditions when family members, such as mother and father, brothers and sisters, have a predisposition to mental health issues. We know that there are genetic links to conduct disorder, bipolar disorder, depression, ADD and ADHD, schizophrenia, anxiety, and OCD. We also know that there's a significant impact on environmental influences, both in the prenatal and postnatal period. We know that vitamin B, folate, folic acid all impact central nervous system development and can have a significant role in brain development when these are deficient. We also know that maternal stress hormone levels and child stress hormone levels definitely impact the development of the central nervous system and how neurotransmitters respond to stressful situations. And we know that children that live in chronic stress have a much different response to stress later on in life and are very reactive and difficult to calm and console because of those predetermined pathways that are set up by recurrent exposure to stress. So how do we help take care of patients that have a predisposition to mental health issues? The key is in the primary care setting we need to be both screening and working on parenting skills. So parenting is the greatest protective factor against the development of mental health illness. We know that children that have a predisposition to mental health disorders but are raised in a nurturing and stable environment have a less of an incidence of those mental health disorders actually coming to fruition. So the best thing that we can do is to observe the parent-child interaction, make sure that there's healthy bonding and warm and loving interactions occurring between families, and also obtain a good history of the psychosocial issues that the family may be going through. We need to make sure that we are able to teach healthy parenting interventions to families and explain and educate the importance of the role of the parent in forming the child's sense of self-worth and self-esteem. And we know that a positive self-esteem and self-worth is a protective factor against the development of mental health issues and substance abuse. So there are several different family-related or life-type issues that are triggers for mental health issues. We know that children who live in homes where parents are suffering from a mental illness such as depression or anxiety or have a higher likelihood of they themselves having a mental health condition. Also, how the parents were raised and how they grew up is often a predictor of the way that they will interact with their children as well. Also, any recent changes in the family dynamic, such as divorce, separation, death, um, poverty, homelessness, all of these things will certainly predispose, send a predisposed child into a mental health condition, or at least increase the chance that that may happen. So I wanted to discuss a few of the most common pediatric illnesses from a mental health standpoint. Anxiety disorders, these typically appear early on in the preschool years, so 3, 4, 5-year-olds. A lot of times these children are characterized as worriers. Usually we see a shy child with some parental dysfunction and also a family history of anxiety. 9 and above is a general anxiety disorder. This is when this normally begins as far as diagnosis, but usually we see some signs of this early on in life with the child being a quote-unquote worrier. So the symptoms of generalized anxiety disorder are fatigue, somatic complaints that have no physiological cause, such as abdominal pain or headaches, restlessness, difficulty concentrating, which again may be misdiagnosed as ADD, and you may see some school impairment because of the anxiety. Poor sleep and excessive worrying. And I've also seen children with generalized anxiety that are very, very clingy and afraid to leave parents for reasons that are unjustified, like fears of them dying or getting in an accident, and therefore they want to avoid school to stay home with the family because of this unsubstantiated worrying. Depression, major depressive disorder, I wanted to kind of define what that is, and we certainly see that in the primary care setting. Major depressive disorder is characterized by depressed or irritable mood or markedly diminished interest in almost everything that the child normally does for at least 2 weeks. And as adolescents and children get older, there is a higher incidence of major depressive disorder. So what we see clinically is the patient presenting or someone bringing them in concerned because they are exhibiting a sad, depressed mood, angry, loss of interest, perhaps have gained or lost weight. They could be sleeping more or not able to sleep. Fatigue, difficulty concentrating, feelings of guilt and recurrent thoughts of death or suicide, and certainly a child that's going through a major depressive period can present like they have ADD as well. And again, this is another thing like anxiety that may be misdiagnosed and given a label of ADD because of the difficulty concentrating. So treatment options for child and adolescent depression. The best treatment combination, as evidenced by the research, is cognitive behavior therapy in the form of counseling with a mental health provider plus a selective serotonin reuptake inhibitor. And so fluoxetine and escitalopram are the only SSRIs that are approved for pediatrics. And we do see some use below the age of 12. However, it's important to note that these two are the only SSRIs that are actually approved for children. There is a caution for providers to avoid paroxetine due to an increased risk of suicide with that particular SSRI, and sometimes that is associated with no change in mood, but a change in activation or energy. So we have a child who previously would have suicidal thoughts but had such a low energy level because of the severe depression that they didn't act on that suicidal ideation. However, once they are started on the SSRI, there can be periods of mania, or there could be periods of still that flat depressed mood but more energy to actually do something harmful to themselves. So that needs to be an education point for parents, and it also needs to be specifically discussed and monitored for by the provider. So certainly ADD and ADHD are prevalent in the primary care setting. This is a mental health disorder that can be both screened for, diagnosed, and treated in the primary care setting. And there's different types of ADD or ADHD. We have the attention deficit hyperactivity disorder, and then we have sometimes just the attention deficit component without hyperactivity. And then we have some that are more towards impulsive behavior. And so it's important to kind of know what subtype of attention deficit disorder we are dealing with. So this is a significant disorder that impacts the school function. Also, there's higher incidence of injury. Certainly children that are riding bikes and in and out of traffic and running out into the road, and drivers once they get into the teenage years, when they have that inability to focus and have the impulsive behavior, this is a setup for higher injury incidents. And so what's actually going on physiologically is in an individual that has ADD or ADHD, there's changes in the prefrontal cortex, where information typically is organized, regulated, distributed. This is kind of that decision-making center in the brain. And so we know that by MRI that there are actual physiological changes in individuals that are suffering from ADD and ADHD. And so it's very important to note that individuals that have ADHD will have this disorder in more than one setting. So it's very, very important to make sure that we are diagnosing this properly and that we are looking at both parent information and information from the school. So there also are a higher incidence of comorbid issues, both psychiatric and learning disabilities that accompany ADHD. So a lot of times these children will have difficulty reading, speech, language development, oppositional defiant disorder, anxiety, self-esteem issues, certainly if they're having trouble making friends because of the hyperactivity and impulsiveness. And so we want to consider that there are often more than just the ADHD issues going on in children, and screen for the comorbidities as well. And so how do we diagnose ADHD? There are several validated tools. One particular one that I find easy to use is the NICHQ Vanderbilt assessment. And it's, again, I can't point out enough that there has to be these type of behaviors in more than one environment. So the 7-year-old child who comes home and is bouncing off the walls and hyper all evening and is driving mom and dad crazy, that is not diagnostic of ADHD. We really have to make sure that the child is not just coming home and after being in a restricted environment where they're forced to sit still throughout much of the day, coming home and kind of blowing off some steam. So we need to make sure that the ADHD, if present, this will actually impair their school functioning as well. So these are children that cannot function without some sort of accommodation or intervention. And a link below is a direct link to the Vanderbilt screening assessment, and there's a downloadable form for both parent and teacher, and you send those home with the family and ask the parent to fill it out and ask the teacher to fill it out as well and have them bring that back. So we don't ever want to start any kind of medication without having objective data that show that the child is not functioning in the academic environment. So ADHD treatments, it's important to remember that ADHD is a hyperkinesis, a movement type disorder, and there's an impulsive component to that where children act first and think later. And the stimulant class of medication, such as methylphenidate and amphetamine compounds, have been around for a long time. There's a 79 to 90% chance that a child will respond to stimulants. They work very well in children that have ADD and ADHD. And how they work at the CNS level is they actually block the removal of dopamine and norepinephrine in the brain, and so those neurotransmitter levels are increased. And if diagnosed and treated properly, what we should see is an immediate improvement in the focus and attention, decreased impulsiveness, and a decrease in unwanted motor activity. So, sensory processing disorder, this is a newer diagnosis, maybe in the past decade or so. And what this is a difficulty with modulating and integrating sensory input. And so there's some characteristic symptoms or clinical presentations that you will see for children that have sensory processing disorder. And certainly some children with ADHD and ADD will also have sensory processing disorder, but it can be a standalone diagnosis as well. And these children you will see described as being very hypersensitive to noises, smells, other people. They just get quote unquote stimulated and overstimulated easily. These are the kids that can't stand certain textures, they can't stand tags on their shirts, things that normally we wouldn't notice, just kind of pushing them over the edge from a sensory standpoint. They also will have trouble often making friends, they have trouble with their motor skills and in constant motion, and don't have a good understanding of that personal space. They will often have trouble with fine motor skills and difficulty in handwriting, and can be described as a clumsy child. Now, it's important to note not every child will have all of these, but these are some of the common complaints that we see in children with sensory processing disorders. And so this is treated with referral to occupational therapy, where they can both help with the diagnosis and then help with the treatment. And they do a variety of therapies for this that help the processing center in the brain to learn how to modulate all of that sensory input that we have coming in at any given moment throughout our day. And so they use such things as weighted vests and brushing, light and harder brushings on the skin. They do vestibular type therapy. A lot of these children will have trouble with their balance, and that type of input as well. So they do work with proprioception, and a pediatric occupational therapist should be well equipped to take care of the children that have these clinical symptoms. And then the autistic spectrum disorder, this is a kind of a hot topic in pediatrics, and one of the reasons why is that this is a disorder that we see in the first 3 years of life. So we need to be screening, and the American Academy of Pediatrics recommends 18 and 24 months of age that we do a regular routine validated screen for autism, and the modified checklist for autism in toddlers, or an MCHAT, is a very common and validated tool to screen at those periods. So I'd like to refer you to the MCHAT and reading some of those questions that are on there that will help with diagnosing or at least raising red flags for ASD. And one of the main things that we see with this is a severe delay in speech and social communication, as well as the incidence of like hand flapping and different repetitive behaviors and interests. And a lot of times these children will appear to be like quote unquote obsessed with a certain thing, and they'll know everything there is to know about one certain thing, like trains or cars or just whatever it is that they're interested in, and that's the only thing that they can really communicate about or choose to communicate about. So I would encourage you to look at the MCHAT and look at some of those questions to get a better understanding of the clinical picture. And then lastly, I wanted to mention substance abuse and the incidence of this in adolescents. I can't be emphasized enough that we have to screen for this in the primary care setting, and certainly we need to have parents in the room to do the initial psychosocial evaluation and talk about family history and family dynamics. But then we need to ask the family members to leave and interview the adolescent alone, or they're not going to give you an accurate history of substance use. So we want to start with with general questions just about their friends and what they like to do, and ask about specific substance use in the home, and we want to keep a very non-judgmental and non-reactive attitude to this. We also want to make sure that they know that their interactions with the provider are confidential, and certainly unless there's something that's an immediate risk of harm, we need to keep this information confidential. And the CRAFT questionnaire is one validated tool that can be used in primary care. And when asking those questions, if there's a positive response in 2 or more of the areas, then we need to look further and discuss referral. So that concludes the presentation on mental health issues.